right, good evening, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, and I'll be your moderator. We're excited to welcome three expert speakers for tonight's webinar, Dr. Deborah Birx, Dr. Don Cohen, and Dr. Fiona Collins. If you have questions during the webinar, please type them into the Q&A section of your control panel, and we'll answer them live at the end of the presentation. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand. And this webinar is sponsored by Health First and ActivePure Technology. So with that, I would like to throw it over to our panelists.
Thank you, Adam. My name is Dr. Don Cohen. A brief bios all around. I'm Chief Clinical Officer at Health First on the Foundation Board at OSHA, and I taught at Columbia University School of Dental and Oral Surgery, as well as being an attending at Columbia Presbyterian Medical Center. We have on this call Dr. Deborah Birx. Dr. Birx has been involved for decades in HIV and global AIDS research, as well as she was engaged in global research on TB and malaria campaigns. Most recently, Dr. Birx served on the White House Coronavirus Task Force. And as we all know, that has helped to bring us the vaccines that are out there now. Additionally, we have Dr. Fiona Collins. Dr. Fiona Collins is a renowned international and national speaker on infection control. She has lectured throughout the world, North America, Europe, Pacific Rim, Middle East. She's been a faculty member at the OSAP Boot Camp and its annual sessions. She's a member of the American Dental Association and has been their representative to AME. She's on the ADA Standards Committee and working groups, and has always been involved with OSAP, as well as a fellow of the Pierre Bouchard Academy. So we have a pretty neat kind of panel, and I'd love to just get right into it. So if we could, next. So I wonder if I can just put this right out there for Dr. Birx to start.
Great. Thank you, Don, and thank you to Henry Schein, and thank you to Dr. Collins for joining us on this important webinar. And really, thank you to each of you who really have had interest in protecting your patients and protecting your staff. And thank you for being there during COVID. A lot of us had to see you, despite the fact that it was a very difficult time, and it remains a difficult time, I think, for practices around the United States. But we heard from a lot of you during my time in the White House, and I want to thank you for raising your issues, and I want to thank you for everything you've done for bloodborne infection control. I know a lot of you had to do a lot of changes in the 80s. When HIV/AIDS came to be in the fruition. But we were just talking, Dr. Collins and I, about why we didn't take hepatitis B as seriously. And so sometimes it takes a big issue like this, like coronavirus, for us to really be paying attention to transmission of respiratory viruses. So what I wanted to do today is talk to you a little bit about what we know and what we don't know about the current pandemic and where we are today. So the current surge that we're experiencing that is across the Sun Belt is very similar to the summer surge last year, but there's a more rapid increase in cases and more rapid movement into other states that weren't always impacted by the Sun Belt surge last year. And I think for all of this raises significant concern about what could be in our fall and winter. For those of you who remember, the summer surge was about 1/3 of the fall and winter surge that the United States experienced. And we're going to go through some of those slides just to remind you about what we've been through together for the last 18 months. I know you know that the vaccines have clear protection against significant disease. So the vaccines were formulated and they were emergency use authorized for their ability to protect against severe disease, both severe disease resulting in hospitalization and severe disease resulting in deaths. The vaccines were not significantly studied to look at transmission or protect against subclinical disease. Their primary focus was severe disease, and that's how a lot of our vaccines work. The only vaccines we have that protect really well against acute infection as well as clinical disease is some of our live attenuated vaccines, our MMRs. And so those are live attenuated vaccines. These are obviously not that, but the vaccines are clearly doing what they were made to do and protect against severe infection. That said, you have to have a good immune response to protect against severe infection. And that's why you hear the current administration talking about the need for a third shot. I'm not even going to call them booster, a third shot in those who may have had a suboptimal immune response. And that's why you're hearing about boosters for individuals that may have waning immune responses. And that's where you get the 8-month piece. Now, the new data that has come out has shown that vaccinees have a transient level of viral load. That's how high the viral load is in their nose, equivalent to non-vaccinees. And that's why with this Delta variant, we're concerned about transient transmission potential. But most of us will not have symptoms. And so the only way that you can find that is through testing. And it becomes even more important with your clients and with your staff that you may have many clients without any symptoms who could be vaccinated and could be shedding virus. And I think this is why we wanted to talk to you about air and what can be done to protect the air. Finally, we don't know about this full protection for the most vulnerable groups. And frankly, we don't know if the really super frail elderly will ever be able to mount a significant immune response. And I think that's what NIH and CDC are looking at right now. I think many of you who know with elderly patients, we had to alter the flu vaccine to increase its immunogenicity. And so that's really an open question still. And I think that's why they'll be very interested in looking at the impact of boosters across our most vulnerable elderly. Next slide.
So if we could, there's a poll question that I think would be really appropriate to bring in here. And if we could, Adam, could we put that in there? And the logic of bringing in this poll question, as you can all see, we're really interested in seeing how this has affected each of you and your practices. We know, and we've all read, that there's some significant employee issues here, especially in the dental teams and hygiene. So we'd really be interested in seeing this. And I don't know how much time we're going to give this. Adam, need a little help on that from you.
Yeah, well, we'll give it a little longer. The responses are rolling in. It's looking like right now, pretty close between employee and both at around 40%, with patient being the lowest of the three.
Cool. If you would, everybody, please continue to respond on the poll. And let's go back to Dr. Birx's slides if we could.
Great. So this is, and I think you all remember this is beginning of April 2020. And that original surge that we saw, many of you saw the pictures from New York. That was really an entire New York City metro area, extended into the northern New Jersey counties, into Connecticut, into Rhode Island, and of course out to Long Island. And so that was a very significant, a majority, I would say 40% of the cases in April were due to New York. Also New Orleans, and you can see that there. You can see Detroit, Michigan. You can see a little bit of Chicago. You can see it moving into Boston. It moved down the East Coast into Philadelphia and then Washington, D.C. I wanted to call your attention just to remind you, and I know you know this, that Four Corners area where you also see the pink and the orange, the Arizona, New Mexico, Colorado, Utah, that's our Navajo Nation. And so some of the pinks and oranges you see on this were the very early impact of the virus on our tribal nations. And it's just something to really remember throughout this COVID outbreak. The group that was most adversely affected are our tribal nations. I also wanted you to see this little corner of Georgia. Now, you may have remembered in the news, that was Albany, Georgia, and that was a county outbreak. These numbers are corrected per 100,000 population. So this is a rural county in Georgia. This was a single funeral event that resulted in really literally hundreds of infections in that county from one single funeral. So there were super spreader events, even with the original variant. Next slide. This is what May then looked like, and May, New York was beginning to improve, as well as the entire East Coast. You can see the Navajo Nation really getting impacted at this time. And you can see some of those very dark red counties. Those were very specific outbreaks in nursing homes, in prisons, in meatpacking plants, in large manufacturers. Next slide. And then Memorial Day happened. And you can see after Memorial Day, we start to see infections spread across the South, starting in Alabama and Mississippi, and then going across into Florida, New Jersey, and South Carolina. And this was the beginning of the Sun Belt outbreak. July. Next slide, July. Yes, and you can see how prominent it goes across the Sun Belt, Southern California, across to Arizona, Texas, and across all of our states across the South. Next slide, into August, which was really the height of the Sun Belt outbreak. And then things started to improve in September. Next slide. And in September, you can see the Sun Belt is looking better. But now we have the Heartland, Wisconsin, Minnesota, North Dakota, and South Dakota. And what happened was there was rapid cooling among our northern plains states and drove people indoors. So now you're beginning to see that the Sun Belt outbreak that occurred in the summer was because it got very hot and people moved indoors and brought family gatherings indoors. And the same thing happened in reverse as it got cold across our northern states. And this continued to build from September into October. And you can see how bright the country becomes. That then moves into November, right before Thanksgiving. So this is a country right before Thanksgiving, and you can see how significant this fall to winter outbreak was. It was a very rapid rise in cases. And this was, we assume, part of the original variant, although the United States was not sequencing adequately enough so that I could even tell you whether we had our own more transmissible variant during that fall winter timeframe. The next slide is right before Christmas. And you can see actually things start to improve across the country right before Christmas. Next slide. And this is the impact of Christmas in a couple of states, although we did not see the same devastation post-Christmas and Christmas gatherings that we saw after Thanksgiving. We reached our peak about the first week between the 8th and the 10th of January in cases. And as you know, hospitalizations and death continue to lag through January and February. Next slide is February. And you can see across the country improvement. It always improves in the way that it got bad. So you can see the northern plain states are looking much better compared to the rest of the country. And now March, where things continue to improve. And you can see this dramatic improvement in March. But then comes the Alpha variant, which is the UK variant, arrives the end of March. Next slide. And you can see the outbreak that it caused in April. Primarily a Michigan and Minnesota outbreak, but also into some of the Northeast and Florida. And so this is really the UK variant. And then if you can go to May, where things again improve, and then June. And June is that time period between the UK variant and the arrival of the Delta variant. Next slide, July. And you can see the building cases. Almost all of these are now Delta variants. Next slide. August. And so the geography is very similar to what we saw last year, but the rate and speed of cases development, and the rate of spread. I just want to remind you where we were last July. Next slide. So you can see, and then go back again to August. So you can see the movement into the northern areas is much faster this August compared to last year. So next slide. And then keep going one more. Okay, so what about these variants? So first we had the UK variant. You saw the outbreak that it caused in Wisconsin and Minnesota and a little bit in the Northeast. And now you can see the Indian variant, the Delta variant, and really building across the South and moving up through the north, up through the heartland and towards the northern plain states where it will cool. Now, how does this happen? Well, the original strain was about, each person infected about 2.5 people. With the UK variant, it was 4, and now it's 6. So it's more than twice as infectious. We don't think it's significantly more, leads to significant more fatalities, but certainly it is making younger people sicker than we saw with the original variant. Next slide. Now, in the midst of all of this, and this is just a summary, and I use this as an advertisement that if you go to HHS Community Profile, this was the data analysis that we created and got up on the website in December of 2020. They're continuing to update it. It's updated about every other day. So HHS Community Profile, it goes down to the county level and includes all the large metros so that you can see what's happening, and includes these maps. So at any one time, you can see what's happening in your neighborhood, but you can see across the board, test positivity cases, deaths and hospitalizations are rising, and the rate of rise of hospitalizations is much greater than the rate of rise that we even experienced in the fall and winter. And I think this is why you hear the depth of concern is the rate of the rapidness of the rise, again, illustrating the degree of contagion. Next slide. Testing. Now, I'm a big proponent of testing because testing is the only way to find the subclinical cases and to stop that onward going transmission. Testing has fallen from 2 million a day. It fell all the way down to under 500,000 a day. It's finally back up to 1 million per day. We have the capacity to do to 3 to 4 million tests per day. It dropped, and you can see that slide on your right-hand panel is it dropped across all age groups. So all age groups decreased their testing going into the summer. And so we were really very blind to how this epidemic was expanding. And we waited, once again, too long, because we waited until we started seeing people coming to the hospitals. By that time, you've got incredible community spread. Next slide. Now, this slide is really important because it looks at test positivity across age groups. Now, these are national numbers, and it's from a few days ago, but you can see across the country, test positivity rose in every single age group, including the highly vaccinated over 65. So we know that there is both clinical and subclinical vaccine breakthroughs, but vaccine is holding in its ability to prevent people in general from very severe disease and hospitalizations. And that is seen in the slide on your right-hand side. Now, the largest group with the highest rate of hospitalizations are people, once again, over 70. And so once again, the virus is getting into our nursing homes and impacting the most vulnerable. Even though many of them have been vaccinated, we have to really understand that many of them may not have had significant immune responses to the vaccine. And so once again, the over 70-year-olds are being impacted. And so this is my public health warning to all of you. Please protect small children and the elderly. We know that they're particularly vulnerable to this particular Delta variant, and we just want to make sure people are protected. And that's why we're asking people, both vaccinated and unvaccinated, to wear masks to protect those individuals who are individuals from us that are vaccinated and may have subclinical infection and be able to spread the virus. And next slide, I think it's my last, or this is my last, and then we're going to go to our next speaker. So the current surge is in similar geography, but because this current variant is 3 times as contagious, it takes much less exposure and much fewer people exposure. So let's say you saw 10 clients a day. With the old variant, that probably wouldn't have resulted in staff potentially being exposed. But now with these new contagious variants, less exposure, lower amounts of exposure are leading to infections. And again, the vaccines protect primarily against severe disease and death. They may not be effective in preventing viral shedding from the respiratory tract. and it may not be effective in preventing transmission to others, although at a lower rate compared to the unvaccinated, because we think the vaccinated group may shed for a shorter period of time. Those of us who have been vaccinated are more likely now to be asymptomatic and unknowingly be shedding the virus to others. Vaccination alone won't potentially be enough to ensure that you and your staff are not exposed to these new evolving variants from your clients. And that's why we want to talk about the potential of dealing with your air quality in your spaces, but also this is why we keep pushing that with masks. Unfortunately, in most other medical areas, and so if you go to the emergency room, the patients are in masks and the doctors and nurses and the assistants are all in masks. You can't do that because you work in people's mouths. So that puts you at unique risk compared to this virus, compared to most of the other healthcare community. Consider COVID antigen testing of your clients. It's a cheap and easy test. You can do that as clients come into your office. It's 15 minutes. There's a whole set of them available over the counter that you can buy. They're about, and if you went to one of the manufacturers, you could probably get them for $5 to $7 a test. Currently for us, they're about $12 a test if you go to your CVS. But this is a good way. If you're shedding antigen, you're infectious. So as opposed to nucleic acid tests, which can remain positive for a long time, most people that are antigen positive are actually shedding virus. Realize though, this test is not 100% sensitive or specific, so you could have false positives and false negatives. But we'll talk the rest of the time on additional steps that you may want to be taking to protect your employees and certainly your clients from persistent aerosol clouds of viruses, not only COVID-19, but flu, RSV, and other respiratory viruses that are circulating across the country. Always pay attention to break rooms in any location where your staff will be on mask, and consider adding increased layers of protection and limit occupancy in those areas to make sure you decrease exposure to potential aerosols from one staff to another staff, again, of subclinical viral shedding.
Cool. Dr. Birx, thank you. Seeing the progression over this last year and a half, I don't know if it makes us comfortable, uncomfortable, but I guess as one question that did come in, and that was, where do you see the future going then based on the past?
Well, first, it would be terrific if we could get all of America vaccinated. I think that's really critically important, but we can't wait for that. We're facing a fall and winter. And so we have to deal with the reality that we're all facing together like we had before we had vaccines. And that reality means really doing those things that protect you against aerosolized spread. I know that a lot of you want to start gathering again. Just remember, even vaccinated individuals could be shedding virus. And I think until we can really get our children protected, we still have to be really careful about our gatherings. This fall will really tell us whether we were able to achieve enough vaccinations to preserve our healthcare delivery system. And I think that's really what you see happening across the South. If that happens across the North and the Northeast, that will be very devastating. These are large population centers. And so that's why I think find everyone very concerned about what's going to happen in the fall and the winter. Now, of course, this virus continues to mutate, and the virus wants to mutate to a more transmissible form. It doesn't want to mutate to a more deadly form because viruses can't exist without us. And so if viruses kill us, there's not enough of us to transmit the virus. It's optimal for the virus to have us very low levels of infection so we can just keep infecting each other and the virus can continue to replicate. And so that's the concern about the continuous. Remember, the Alpha variant came from the UK. The Delta variant came from India, the Beta variant from South Africa, the Gamma variant from Brazil. So, and you're hearing now about variants from Peru. And this will continue to happen until we can get the globe significantly either have natural immunity or vaccine protection.
Thank you. Thank you again, Dr. Birx. One quick comment to throw in? Nothing about this. We've had a number of requests. This is being recorded and will be made available to everyone over this next short period of time. The slides will not be made available. But another question for you, Dr. Birx, that came up, and that is, when do you anticipate or hope that vaccinations for children under 12 will be made available?
So that's really a critical question. And I think the reason, and people are probably like, well, how did that first group happen so fast? Well, the first group was considered more adult-like. The 12 to 16 and the 12 to 18-year-olds. And so they were able to do bridge immunology studies to prove that the vaccine was as immunogenic in the 12 to 16 or 12 to 18-year-olds, depending on whether it was Pfizer or Moderna, and to show that it was safe. Now, when you have children under 5, there's a lot more hurdles that the FDA always has made us go through to really prove that it has a benefit for that child. So you can't just immunize the children to protect us. You have to immunize the children to protect each other, and really be able to show that the risk benefit is in the children's favor. And so that's why they're asking the companies to look at more children, to provide more safety and efficacy data. We have great, I mean, when you immunize, when you give out 150 million and 200 million doses of these vaccines, you know that they're safe, and you know, by and large, they're highly efficacious because we have that data in adults. The children, they really want to have a larger database, not millions, but they want to really make sure that this vaccine is safe and immunogenic in children under 5 before moving. I think the 5 to 12-year-olds will come in the fall. It's really a question when the under 5 situation will be resolved, because I know a lot of people out there with young children who are very worried about their children and exposure to COVID.
We've also had a number of questions come up with regard to the 3 key vaccines, with regard to Moderna, Pfizer, and of course, J&J, especially J&J, which has had a more complicated history, for want of a better description. Your thoughts there?
So these vaccines, all of the vaccines, primary, we had a roadmap of what kind of immunity was necessary. And so when people say, why was this so fast? It was because there was more than 2 decades almost of work on coronavirus because of SARS. And so people didn't stop working on vaccines. And this spike protein was shared the same kind of, it's not identical, but that same kind of approach was being considered for the original SARS and then for this. So these were vaccines that if any of them worked, they were all going to work to some degree because they were all targeting exactly the same element on the virus, this spike protein. So the mRNA vaccines are one group, and of course the vectored vaccines, of which J&J is one and AstraZeneca is another, that's being used globally. And there's a third kind of vaccine, what we call a protein subunit vaccine. It's been made by different manufacturers around the globe. Here in the United States, Novavax is being studied. Now, those of you who are in the vaccine world will remember that some of the best immune responses occur from a prime and a boost. And so we've all been primed now. Either we've been primed with J&J or we've been primed with Pfizer or Moderna, and we can now be boosted by any of those vaccines or even the Novavax vaccine if it became approved. And so that is the advantage. And that's why the federal government didn't stop after it had clearly an efficacious vaccine. It wanted to make sure it had the spectrum of vaccines. And so that we could improve on the immunogenicity, particularly in that cohort that I was talking about. Subunit vaccines can get different. It's similar to what they do use for hepatitis B vaccination. And so, you get 3 of those shots. But it can also be adjuvanted. That's the thing that comes with, that we combine with the antigen that we want to really boost that immune response. And so for those of you who have been primed, when the federal government says to come and get your booster shot, any of those vaccines will act as boosters to any of the other vaccines.
Great point, and thank you, because that's another one of the questions, of course, that came up. I've had the Moderna series, but the booster may be available. So thank you. If we could go on to the next slide, please. And for this, could we have Dr. Collins begin?
Yes, thank you. Well, obviously, we're most concerned about COVID-19 at the moment. That's certainly emphasized by the unfortunately tragic history and trajectory of the pandemic that Dr. Birx has gone through. So we really are legitimately most concerned about COVID-19. But as we can see here, there are many more that we need to be concerned about. There are plenty of other microorganisms, and this is by no means the whole list, where airborne transmission plays a role. Is it really a problem? When I was speaking recently, one person said, well, do we really need to do all this? And it wasn't about airborne transmission. I said, well, it's about reducing risk and minimizing exposure. So as we look at this, there was testing done in hospitals, and they looked at what airborne microorganisms were present. And across the studies that they were looking at, they sampled the air, they found varicella zoster, they found, not surprisingly, the measles virus, influenza viruses, Mycobacterium tuberculosis, RSV or respiratory syncytial virus, rhinovirus and adenovirus, of course, but also other microorganisms. And many of them were less than 5 microns in size. And we'll talk about the relevance of that later in the presentation.
So Dr. Collins, if I could, I'm going to interject. The question on the bottom of the slide, I think, is one that we all need to think about. One, what's coming next? And what should we really have most concern for?
The question of what we should have most concern about is a difficult one to answer. We don't have a crystal ball, but we can certainly look at it more holistically on what we should be concerned about doing. In terms of what's happening at the moment, I think the biggest concern would be what other variants are going to come out onto the environment. If we're lucky, it's ones that are less virulent, less transmissible, and cause less severe disease. If we're unlucky, it could be more transmissible and more virulent and have a much more devastating effect. We don't know where that's headed. And hopefully, to Dr. Birx's point, we can head it off at the pass. We know about Candida auris, which I know is one of your favorites, Don. That's now a microorganism of concern. It's not prevalent yet, but there have been 2 outbreaks documented, one in DC and one in Texas. The most concerning part of this is that there are strains present now that are resistant to all antivirals in existence, which means you can't provide active treatment should a patient become infected. And if they do become infected, the outcome can be literally very severe and death. So as we look at it more holistically, we want to look at it preemptively and assess and reduce the risk.
To that point, a good question came in again, and this had to do with how does antibiotic and antimicrobial resistance affect existing and we're seeing even emerging pathogens? How does that come in?
So it's really a huge problem. There are more and more microorganisms that have developed and are developing antimicrobial resistance. There are more microorganisms that are developing multi-drug resistance. So whereas previously perhaps it was one drug that didn't work, now it could be several or all of the ones that are effective on a particular microorganism. So it really is a severe problem. And if you were to ask me, would I be more concerned about a more prevalent microorganism or one with antimicrobial resistance and developing multi-drug resistance, provided they are equally serious as in a disease process sense, I would be much more concerned about the antimicrobial resistance and the development of more multi-drug resistance and more microorganisms with antimicrobial resistance. It's to the point where about a quarter of patients that go into hospitals end up with a hospital-acquired infection. So really, it's a significant concern. But overall, if we look at the risk, I'd say if you think about it, it's a bit like building and maintaining defenses in the rivers or on a coastline. Instead of waiting for the evidence that a breach is occurring or has already occurred, we really need to be looking preemptively at what else we could be doing to prevent transmission of disease. We're all, of course, familiar with this chart, and we're looking here at the hierarchy of resistance. It's another consideration in the risk profile. How easy is it to kill? What does it take to kill it? In this sense, one of the ironies is that, in fact, SARS-CoV-2 is one of the easiest microorganisms to kill. And we can see it, it's under, obviously, the coronavirus group, lipid medium-sized virus, along with HIV, HBV, and HCV. And going back to the point Dr. Birx made earlier, if your age is with me or older, you will remember in dentistry, whether you're a dental hygienist, an assistant, or a dentist, practicing what we called wet-fingered dentistry, no gloves. Looking back on it, it was really dreadful, but we didn't think anything of it at the time. So we had to change a lot when HIV appeared on the scene. Although again, we should have already been doing that for hepatitis B and hepatitis C. So we adopted gloves, we adopted much more rigorous personal protective equipment, or PPE, and other practices that were more rigorous than previously. And we're really in the same situation again. We're in a situation where we need to be more rigorous and have been more rigorous and successfully in the last year within the dental environment on what we can do to prevent transmission of airborne microorganisms in general, and at the moment, of course, specifically SARS-CoV-2. So this slide is really important. And I know that both Dr. Birx and myself are going to participate on this one. So the first one is, what size are they? How large are the particles? The other question, of course, is, does it matter? So if we think about aerosols, they contain particles that are less than or equal to 50 microns, and they're in a gas. In the context we're talking about, the gas, of course, we're talking about air. But they contain pathogens within the particles in the infectious aerosol. So there are many that have been found. We talked about some of them earlier in analyzing even cough and breath aerosols. So it's not just obviously aerosol generating procedures. They found numerous viruses with particle sizes less than 5 microns, as well as Mycobacterium tuberculosis and Pseudomonas aeruginosa. So the size becomes really relevant when we look at the other questions of how long does it remain in the air? How far can it travel? And in particular, what happens to it, to us, when those particles reach us? So how long do they remain in the air? Well, the smaller the particle, in general, the longer they can remain in the air. We talk about the larger particles settling ballistically, but even that is not, that's really a simplification, because there are situations where even droplets that we expect to fall ballistically have been found to travel as far as 6 meters, or about 20 feet. But of course, the droplets also dry out rapidly within the aerosol. So you end up with droplet nuclei, which are much, much smaller, many less than 5 microns. And so those travel much further as well. So when we look at the smaller particles, it's well documented that they can travel more than 30 feet, but it also depends on the airflow and how strong that airflow is. So there is potential to travel further. I can remember having discussions at the beginning of the pandemic when it was really getting going. We didn't know as much as we could, and I had a discussion where we're at in heights. Are we going? But it's 6 feet. Surely 6 feet is enough. I said, no, we're going to keep 30 feet away from other people, and so that's what we did. Retrospectively, I'm really glad we did. We also wore a mask if we came across anybody. So we really took all the precautions we could, as many of us did, both in our personal lives and in the office. So really, the question of how far can it travel is really, in a nutshell, a lot further than we would like. But we need to be aware of it, and we need to proactively deal with that.
So if I could throw in, Dr. Birx, your thoughts on what masking should be for the dental community, who obviously has strong airborne exposure.
Masking is absolutely critical because what Dr. Collins described is this infectious really fog can remain unseen in your rooms, in your waiting room, in your break room, in your bathrooms, in your corridors, in the elevators. So even if you don't see another person in that space, that virus could already be in that space, and you could breathe that virus in. And so I find often people will say to me, well, there was no one in the break room, so that's why I felt comfortable taking my mask off, and didn't realize that there had been someone who was infected in that break room just a half an hour before. And so we make assumptions about safety, but we should really understand, as Dr. Collins just described, that this virus not only can silently spread between us when we don't even have symptoms, but it can remain suspended in the air. And I think that's why we have these grave concerns, particularly, and why we want everyone vaccinated, but also using additional protections of masking, because we don't want you to get infected even though you were vaccinated. Because we know even people with mild symptoms may go on to develop long haul syndromes. And so we really want you all continuing to be vigilant, just as Dr. Collins talked about. Vigilance right now of masking and layered protection, of increasing ventilation. And we'll get to be talking about what you can do to actually kill the virus in the air as it's remaining suspended really becomes critical.
Right. And, Dr. Birx, I think one of the other things that we maybe don't think about and that has become apparent is particles settle on surfaces. It could be the floor, it could be clinical contact surface, or simply a high touch surface. And we think, okay, that's settled. But of course, we now know that's not true either, because particles that have settled can actually be whipped up into the air again. And they've now found in the hospitals, I'm sure you're very well aware, that people walking on the floor can actually resuspend particles in the air. So that's another reason really to take care of air decontamination effectively as possible.
Yes, great point. Walking and breathing now is moving viruses all around us.
Yep, the invisible enemy. So then the other ones that we have here for discussion is it highly transmissible and how quickly? And where does it reach? Well, as we saw at the beginning of this webinar, we heard Dr. Birx go through the epidemiology, including the transmissibility of the different variants. Obviously, for other microorganisms, it varies. But where does it reach? So I alluded to this when we were talking about the size of the particles. So let's suppose it's already reached you. Where does it go? It will go in your anterior nares. It can then be inhaled to an extent. However, the extent depends on the size of the particles. So if you have particles that are at least 10 microns or under 10 microns, it will reach around this area of the epiglottis. The real danger is the ones that are less than 5 microns in size, because those are deeply inhaled into the smaller airway passages. So that is another reason to be particularly concerned about the smaller particles.
Thank you.
Next slide, please. So one of the things as we look here to bear in mind is to be asking yourself, are we actually performing episodic prevention, or is it continuous prevention? And when you think about what's in there and how long it remains there, that becomes an important consideration. As we look here, we can see on the right-hand side the hierarchy of controls. This, of course, is from CDC NIOSH. PPE is one component. It's not the most effective. In fact, in this chart, as you can see, it's the least effective, but it's still very important. The next one is the administrative controls, or work controls, as you may know them. Examples in the current context would be four-handed dentistry, using high-volume evacuation, or HVE, triaging of patients, teledentistry. All of those change how we work. There are many of the methods that are recommended that are engineering controls. Examples include the high-volume evacuation device itself, rubber dams, and other devices that mitigate aerosols and handle contaminated air. And we'll look at those shortly, including the space technology that's being used in one particular device. So here we can see CDC guidance, and it does involve administrative controls, engineering controls, obviously personal protective equipment. And the guidance is really to have a layered approach. So looking at ventilation and considering adjunctive devices. And the two mentioned are HEPA filters, or HEPA filtration, and ultraviolet germicidal irradiation, or UVGI. There are other devices on the market, and it's important, if you're considering those, to really look at what extra does this do for me as another adjunctive device, and to make sure that there's due diligence performed. And we'll look at that more closely. If we look at the air exchanges and ventilation first, that really is an important factor. How many times does the air within that defined space become replaced, provided the air is well mixed? If the air isn't well mixed, then you've got pockets that are still more severely contaminated than others. The CDC's defined a minimum of 6 air changes per hour, or ACH, as a criteria for an efficient ventilation system. However, for transmission-based precautions, it's at least 12 air changes per hour. The minimum of 6 air changes per hour is actually also being reviewed. And if you look at ASHRAE documents and standards, they will talk about the assumptions that were made when the air exchanges or air changes per hour were developed, the recommendations. It assumes that the air is ideally mixed, that there are no obstacles blocking air. An example would actually be a dental chair. That could be an obstacle. And it was also noted that this was developed in the absence of venting contaminated air back into the room, which does occur with some devices. The objective, of course, of increasing room ventilation is supplying more clean air. And if we think about all of the parts of the cycle of infection, one of them, a pathogen that is present at a sufficient level to cause disease. So really, what we're trying to do is minimize, it would be lovely to eliminate it, but certainly minimize the pathogen, all of the pathogens that are present, so that they are below the level that can cause disease. And in some cases, we don't really know what that level is, so that makes it even more important. So really, that's the objective, is to have more clean air. There are many options to help with ventilation. You can open windows a little bit, crank them open slightly. You can introduce fans, provided you're not blowing the fan from clean air, from contaminated air towards a cleaner air area. Certainly want to avoid that. There are also things you can do with the HVAC. Make sure that that's being looked at properly by an expert and is working properly. There are also filters in HVAC systems. One recommendation is a MERV 13 rather than a lower MERV. It's still, the MERV 13 will remove less than 75% of particles that are between 0.3 and 1 micron. So it's a help, but it doesn't remove all of the particles. The other thing is, depending on your HVAC system, it may or may not be able to tolerate a MERV 13. So that's a further consideration. Dr. Birx, I don't know if there's anything you would like to add to that.
No, that's terrific.
Okay. Another way to look at ventilation is really, one option is to use a carbon dioxide monitor. It doesn't tell you what microorganisms are present, but it does tell you whether you have adequate ventilation in general, and it really can act as an early warning system.
If I could add to that, there was a recent article about a month ago in the New York Times, and they were talking about opening the schools and what type of monitoring, what type of measurements could they use that would be most effective to create a safe environment. And to your point, Dr. Collins, measuring carbon dioxide, comparing internal air to natural ambient or external air, they found to be one of the most accurate at providing a safer indoor environment. So that's a great point.
Yeah, I think one of the other interesting things is Dr. Birx talked earlier about the rapid antigen test that you can do. And in fact, if you look at places like Delaware, many of the schools in the system, they're actually already did introduce rapid antigen testing, and they were performing it in students every 2 weeks. And so that way as well, obviously, if it's a true positive, you already have somebody infected at that point, but you're finding them, and then you can isolate them and reduce the risk of further transmission. So it's really worth thinking about that as well. The other one we have here is HEPA filtration, and that's been used quite a lot, both in medical and dental settings. The CDC does recommend considering a portable one to decontaminate air, preferably one with a powered fan. According to the EPA, They will, on their website, say that HEPA filters can theoretically capture at least 99.97% of particles that are 0.3 microns in size. That doesn't mean they can't capture larger and smaller ones. This is simply the size of particle that most effectively goes through the filter. And so that is the biggest hurdle to overcome. The other thing is when you, if you do select a HEPA filter, they recommend a clean air delivery rate that is high. So that would be the cubic feet of air per minute that device can handle. Obviously, it's going to depend on your facility whether that works. The other thing to remember or works efficiently is there are HEPA, so-called HEPA filters on the market that will describe themselves as HEPA RX or true HEPA. Those are not HEPA categories. So I would caution you if you're looking at something like that or did look at something like that to really be sure of what you were actually getting. The other one that is up here is UVGI. It works continuously as well. If it's upper room UVGI, well, it is UVGI's upper room, then it will work while the occupants are present. So it will provide ongoing adjunctive infection control. The thing to be aware of with UVGI is it will work provided you have good airflow between the lower room air and the upper room air, because you're only irradiating the upper room air and you're relying on the air being well mixed between upper and lower, such that there is an impact on the lower air in terms of decontamination as well. So that's something to be aware of. But there are other devices that we'll look at. Sorry, Don.
Right, I have a question on this, and to lead the audience basically, because here we are, and the title of this is basically based on space technology. What's coming or what has come from space technology, and sort of I guess that leads into the next slide, and what works better, things of that nature. I'm sorry, go ahead, Dr. Collins.
So I think really you want to look at, is it episodic, is it continuous? How effective is it? And is there something you can do more that will help protect you, your staff, and of course, patients? So as we look at these, there are many options. Some of the technologies capture microorganisms. That would be things like high volume evacuation will capture microorganisms when it's suctioning. In saliva and in fluids. We also have extraoral suction devices that are placed close to the oral cavity. They vary greatly. Some of them are closer in and they have a wider area and they have stronger suction. Others have less strong suction, they're further away, or they may be so close that it becomes difficult to work because you can't actually get in there. So those are considerations if you were looking at extraoral suction. The other thing to look at is what is the extraoral suction actually doing after it's captured the microorganisms along with the other particles? Is it venting it to the exterior? Is it venting it at the back of the machine? And if it's venting it at the back of the machine, what is it doing before it vents out of the machine? Is there any kill? Is there any trapping? Or is there both? So those are really considerations if you're looking at something like extraoral suction as an additional adjunctive device. We have others that include filtration, including HEPA filters, but often also other filters as well, and can destroy the microorganism in the device. That means the device has to have already sucked them in from the air to be able to destroy them. There are some where the microorganisms are destroyed in the air. There are others where the filtration occurs, whether it's 1, 2, or 3 filters, and the microorganisms are destroyed in the device and in the air. And when we look at the space technology that we're going to look at, you'll see that that falls into this category and it works continuously and effectively. I do have a comment here about ozone generator air purifiers are not recommended. And that is absolutely true. Ozone, there's the upper good, lower bad. So ozone in the upper atmosphere is actually impacted by UV light, which is great. Ozone in the lower area in the air, if you're in the coast, you might have actually vaguely smelt small amounts of ozone when the waves are blowing up. And so that typical seaside smell is actually the smell of ozone, but it's not a high level of ozone. So if we look at ozone generator air purifiers, in order for those to be effective, they would have to have a level of ozone produced that is higher and exceeds the limits for safety of health for humans and, for that matter, animals. So OSHA has a permissible level of ozone. It's a limit of 0.10 parts per million of exposure for an 8-hour workday. The National Institute of Occupational Safety and Health also has an upper limit. Its limit is less. It's the same level, 0.10 parts per million. But NIOSH's view and their recommendation is that it doesn't exceed that level at any time. So they're not looking at an 8-hour work exposure. The other one is the California Air Resource Board, which I know Dr. Birx is going to talk about later. And that also oversees air pollution control in California, but they are stringent. So as Dr. Birx will explain later, it's still important to consider this, even if you're not in California. So based on all of the evidence, ozone concentrations within the permissible level are ineffective. And you would need to many-fold more for it to kill airborne microorganisms.
Okay. Dr. Collins, could we go on, because this is actually leading into our second poll question, and
Absolutely.
And that actually has to do with HEPA filters. So Adam, thanks for bringing that up. Great. And this point came out, I think, very strongly in terms of as our dental community reports, less than 1% to 2% of our dental community reports of actually having COVID infections. So whatever it is that we've done, whether it's a combination of PPE, disinfection, maybe some of these devices, apparently we've done it pretty well. The point on this question is really be interested in who's gone out and gotten those HEPA filters. And, are you looking, not interested? What is the future?
Well, I can tell you right now that the majority of the people on this webinar do have a HEPA filter. It's even 17% each for no and not yet, but I'm looking, and only 3% are not interested.
Great. Thank you, Adam. So let's move on to actually the point of this webinar. And this is when we talk about some of these adjunctive devices and ActivePure. What does ActivePure do? I mean, the logic on all of this, we've seen devices that collect, and then while they're collecting in the device, it may have a kill with UVC or whatever. But how do we get true continuous protection? Why don't we get into that? Dr. Birx, do you want to jump in there a bit?
Yeah, thank you. And I know we're getting close to the top of the hour, so I'm going to be very concise. So in my mind, we all know that there's less transmission of disease outdoors. Why is that? Because there's actual oxidating components in our outdoor air generated by the sun and generated outdoors that actually helps kill different pathogens in our air. And so outdoor air is actually quite safe. So NASA was developing technology for the Space Center, because talk about a completely closed system where you have to worry about purity of the air and maintaining purity despite all these other experiments you're doing. And so like with dual use technology, NASA had worked on a technology that uses the same, harnesses the power of the outdoor air and the sun to generate those exact same kind of what we call oxidative potential molecules, whether it's hydrogen peroxide or free radicals of oxygen or OH itself. And that really works to puncture holes in membranes of viruses, bacteria, and funguses, and causes them to be inactivated. And so that's really critical technology. That technology was purchased by ActivePure many years ago, and it's gone through 5 generations of improvement to address all the concerns that anyone may have about the safety, ability to produce and not produce ozone, which is obviously critically important to the company. Exploring and ensuring it doesn't produce VOCs or organic compounds in its function, and then doing the hard work of putting together a medical device class 2 application to the FDA. For those of you who have assembled those 600 to 1,000 page documents, understand that the company took safety and efficacy very seriously to create devices that would have utility from medical spaces to the home to actually commercial and private sector spaces, to ensure that we all could have that same experience of outdoor air indoor when you couldn't do anything. You couldn't open up all of the windows. I remember in North Dakota, I said to them, CDC says, you need to open the windows. And they looked at me and they were like, it's 8 degrees. They're like, yeah, no, we don't open the windows in North Dakota. So, every part of the United States is a little bit different. This technology is continuous, FDA approved, has been studied not only in the laboratory, but in real life scenarios. And that was what critically important to me. They go into prisons, they go into schools, they go into commercial real estate buildings, as many of your dental offices are in commercial real estate buildings. And they study that with before ActivePure installation and after ActivePure installation, and look at those microbes that were there before and ensure that they're no longer there afterwards. And I think it's this, anyone who's looking into this, don't just accept what they have on the internet, really find out, are they FDA approved? What kind of certification do they have from California? What kind of certification? Have they taken the effort to prove that their technology is safe and efficient? And I think and effective. And I think what we've all learned through this, and I think the United States did a very good job of ensuring that the tests we utilize were effective and really had good positive predictive value and negative predictive value. It made sure our therapeutics were well studied before they approved them, and has certainly brought us vaccines. And so really study these groups and make sure that they have real life data, not just lab black box data. And I think that's what ActivePure has done. And that's why I wanted to be associated and work with the company, because we can't always be outside. Hairdressers moved outside. Dentists can't really move outside and see their clients outside. And so it's about making your air as safe as it can be and as safe as outdoor air. And I think that's harnessing the technology that NASA brought to us in a continuous, made specifically for sizing of rooms. And so they do spend a lot of time looking at the rooms that need to be protected. They have induct units, they have room specific units. And then obviously this technology and being class 2 FDA approved was to bring this device to what we talked about at the beginning, hospital rooms with very sick patients that had multi-drug resistant organisms, to protect other patients from those organisms. And so that's the power of this technology. It has been utilized in medical situations. It has been now adapted to both the commercial sector as well as the private sector and into the home sector. And I think really finding what your office needs. I don't think any client is going to accept any longer getting even a cold from being exposed indoors to potential other people's viruses. And I think that has really been a game changer. No one is going to accept getting flu, RSV, certainly not tuberculosis or COVID in indoor settings. And I think that's why we're really interested in what it's going to take to provide safe air.
Gotcha. Hey, I read a couple of things on this. One that I was impressed with is that claim, the FDA claim, apparently is a true claim to kill COVID-19. And I haven't seen that in too many places. But the other thing I realized when I was reading, it also states that it kills viruses, bacteria, and fungi, which is really pretty neat considering it's continuous. It's in the room where you are, and yet it's super safe, like in the space station, which pretty much is a pretty good reason for that. I was also impressed recently. I read that there's one of these devices in every Cleveland clinic operating room, which pretty much states your clinical statement of how effective and how safe it is. So that's sort of like as good as it gets. But then to disturb everybody, just so everybody knows, I'm from the Bronx. They also use this device in Yankee Stadium, but as an equal time, equal opportunity, they also have it for the Texas Rangers. So to that point, there are probably a bunch more questions to come out. Please, please, please feel free to reach out to us. I would tell you that the neat thing on this that really turned me on is when you see those robots with UVC that kills everything. The neat thing is they kill us too. This is the one that's continuous. We can be in the room and we know that it's protecting us, sort of a bubble. I happen to be flying next week. There's a mobile device that's made, and I'm going to have that mobile device right on the plane with me. And likewise, I have a slightly smaller device called the Surface Air, and I'm going to a GPO next week because we have to do some demonstrations for them. And I'm going to have that there as well. So I sort of travel with this. A mask is good. Should definitely have the mask, but I love being surrounded by a bubble that's going to kill the pathogens. So
I think that's what's exciting about the technology is it's adaptable to different situations. So continuous, safe, occupied rooms where you can understand the importance of killing. Not only it's been shown to be effective against MRSA. I mean, it's really bacteria and fungi are more difficult to kill than COVID-19. And so a lot of the studies have been done, and we do measure bacteria pre and post and fungi pre and post with all of these real life experiments that we utilize, because those are more difficult to kill than COVID-19, and certainly important in all of our practices to make sure that they have this level of protection. Cleveland Clinic is studying it to really see whether it takes down their OR intraoperative infections that occur. I think all of us want to decrease iatrogenic infections. I think every physician and every dentist around the world wants to make sure that that doesn't happen. And I think it's about protecting clients in the waiting room, protecting staff in the break room, and protecting everyone when they're actually in the chair and no mask can be worn by the client to really ensure that your air remains safe for everyone.
And Dr. Birx, to your point, it's interesting. They make units that actually will go into the HVAC.
Yes.
And can be sized for that. They make units that are pretty big, the size of, say, a large computer for, I don't know, 3,000 square feet, 2,000 square feet. But then they have a desktop model, because that's the one I'm taking on a plane with me. So really, the neat thing on this is it can be anywhere. Today, we had a request from a mobile clinic. So they have a whole bunch of RVs, and they want to put one each of these on their RVs. So as you look at it and you look at this last basic slide, you can see this is how it works. And yet, at the same time, it also has a HEPA filter in it. So you have the ionization, you have the air being sucked in, because remember, without the air exchange, it's not quite as effective. So you're getting all of the parts and pieces that we all want. And to me, that's the winner. Any other thoughts?
That's really the important piece when Dr. Collins talked about how important it is to have the device work throughout the whole room. And that's why these oxidative molecules that are shot out from the machine and cover the space rapidly and then brought into the HEPA filters. So two actions happening simultaneously, continuously. I'm, of course, in a hotel room, and of course, I have one right now in the hotel room. I just want to make sure always that the spaces that I am in are protected.
Cool. I want to thank everyone. Adam, could we move on to the next slide? So for everybody, as you note, there's a bunch of email addresses on here. I want to thank everybody for attending, Dr. Birx, Dr. Collins, and Henry Schein for putting this out. Please feel free, contact your Schein dental rep, whoever. Questions are wonderful, and the goal on this really was to create more questions. And with those questions, we hope we can give you the answers that will make things safer for you. But please don't hesitate to keep asking questions. We will try to respond to all of them, even after this. Thank you all. Adam, thank you for your help.
Excellent. Thank you. Great content. If you all just have a couple minutes, there were some great questions that did come in that I think would be beneficial to ask. There were a couple questions that came in regarding hypochlorous acid fogging efficacy, and does fogging the operatory with the acid essentially help to destroy the virus particles in the air?
Dr. Collins, sounds like right up your alley.
Oh, thank you. So if we think about hydrochlorous acid fogging, this is not a continuous technique. It's an episodic technique that is performed by someone wearing appropriate personal protective equipment without other people being in the room. So if you look at the advantages of continuous in terms of continually treating the air and killing microorganisms, depending on what you're using, but certainly in the case of the ActivePure Medical Guardian, you're killing microorganisms, you're not just filtering them. That is a continuous activity that hypochlorous acid is not, or hypochlorous fogging is not. It is intermittent, and it's really, you're trying to get it on surfaces. So if we think the other one that I saw in a hotel room recently was actually one of the disinfectants using an electrostatic sprayer. Well, the reason that an electrostatic sprayer is used is to create a charge so that that fine mist will be drawn very quickly to a surface. Now, if it's being drawn very quickly to a surface, and that's the purpose of it, again, you're not getting air decontamination. So I think there are reasons to choose continuous efficacy of an air decontamination product that kills microorganisms, both when they're in the device so that they're not being chucked out, but also in the air.
Cool. Dr. Birx, a question for you. If people have had the vaccine and have had COVID, will they need the booster?
Yeah, that's a great question. So let me tell you about how these variants came to be. So variants came to be in these specific countries, the South African variant, the UK variant, and the Indian variant, after a large percentage of the population had already been infected with the original strain of COVID-19. So it didn't protect them about what we call secondary infection. And so absolutely get the third shot. And in the case of J&J, get a booster to make sure that you're protected through the next 8 months. Now, what is amazing is, remember we talked about prime and boost? The boost can produce an immune response far greater than the original 2 primes did. And that may then be persistent for months and months and months. And so it may be that after this shot, you're protected for a much longer period of time, potentially even years. So that will be actively studied.
That's a good one. And thank you, because that one's come around a lot. Here's another one for you. After doing an aerosol generating procedure, how long does the room have to be vacant to ensure the air is cleared? In addition, how does this work in an open ventilation setup? And I'm assuming we're now talking about ActivePure.
Yeah, so that's a really critical issue. And obviously anesthesia and other worry about this all the time. And it's why, of course, these are being studied at the Cleveland Clinic in the ORs, because these kind of aerosolized clouds that we know get generated, we always knew that they were persistent. Now we know COVID-19 is also an aerosol, it can remain persistent in the air. And so that's why I talked about how important it is to have something that's continuously providing these oxidative molecules out into your environment to be penetrating these membranes of these viruses, bacteria, and fungi. And the great thing is that they don't care. They're not searching out COVID-19. They're searching out any bad pathogen in the air. And so you can have a combination of pathogens. You can have flu, you can have RSV for your pediatric dentistry out there. I know you're watching this RSV outbreak. It's incredibly serious. It's a very serious outbreak because we have 2 years of unprotected children now. And so that virus has twice as many candidates to infect. And so a lot of these respiratory viruses are going to be particularly bad in the fall. And that's why we believe these extra layers of protection, of masking indoors and really working to improve the purity of your air through these oxidative type approaches will be critical.
And again, Dr. Birx, does it create any pressure issue in a closed ventilation system?
That's a great question. And that's the remarkable part of how this honeycomb designed and how it doesn't impede airflow. And so that's why it can be put into any duct without having to have any impact on the actual airflow in the building. And it doesn't impact the airflow, of course, in the individual units. And that's really, you want to make sure when you do anything in your ducts that it's not changing the airflow in your ducts, because we just talked about how critical ventilation is.
And what about, again, another question for you, what about questions on the filters and maintenance for these units?
Yeah, that's a great question. And so the company has worked very hard to look at how long the device functions for and decided it functions without any kind of maintenance for well over a year, but have developed a yearly cycle where you just replace the cell. So the cell that's generating these critical oxidative components should be replaced yearly. So and that's about 1/10 the cost of the original equipment.
Excellent.
And it's kind of like, those of you done your refrigerator water filter, kind of think of it like that. It's that kind of system.
Well said. Well said. How do you feel the animal infections have been involved here?
What do you mean?
Well, one of the questions that we got discussed, and I'm trying to get up to that question, and it sort of disappeared, but we will answer it off. What we did get a couple of questions on, and I'm going to throw this at Dr. Collins. The value of pretreatment mouth rinses and of zinc lozenges on the basis of prophylaxis.
Okay, so it's a little bit of a complicated answer to that one. Zinc is obviously an antimicrobial agent. I have not seen any data on the efficacy of zinc lozenges as a preventive measure against the virus. So in the absence of that, I would have to say I don't know. I do know that zinc is an antimicrobial agent. In terms of pre-treatment rinses, and I can't see the question now, it's disappeared. But in terms of pre-treatment rinses, I believe the question was, are they effective? So pre-treatment rinses have actually been used, as I'm sure you all know, for many years to reduce microbial load. What they were looking at was specifically bacterial load at the time. However, there is data supporting the use of pre-rinsing to reduce microbial loads in general, not only bacterial loads. You are reducing the load. How effective a contribution it makes is going to depend on the situation. It's going to depend on what you're using. It's going to depend on what you used. It's also going to be initially reducing the microbial load. However, if you think about long procedures, you do continue to salivate usually. And so there are still microbes that are coming into the mouth after you have pre-rinsed. It's certainly one leg in the armamentarium of reducing bacterial load, with the ultimate objective, of course, of reducing contaminated aerosols from developing in the air. You can't prevent them completely. There are aerosols in the air with contamination if you're performing aerosol generating procedures. But let's not forget, if you speak, if you shout, if you cough, if you talk, if you sneeze, and I usually say, or if you sing, but who does that in the dental office? So they all produce contaminated aerosols. If I can go back for a second to when you were talking, Dr. Birx, about the continuous nature of it and the efficacy. The other aspect, when we were asked the question, how long do you have to wait? Otherwise, if you're in a room, how long do you have to wait after an aerosol generating procedure? Well, I know we used to be worried about 10 minutes at one point when some of the disinfectant products for surfaces took 5 and 10 minutes. There are plenty of options that are faster now. That was operatory turnover. This situation, there were areas where they were saying it's 50 minutes, it's 30 minutes. Overseas, in some places, it was 2 hours and longer. That's really an impractical way to run a dental office or actually any healthcare setting. So the other advantage of continuously decontaminating is you are minimizing the level of pathogen, not only SARS-CoV-2, but pathogens in general on a continuous basis. So I think that's one of the other practicalities of continuous versus intermittent.
And you know, Dr. Collins, I read also that assuming that you're gone for the weekend, you don't turn the unit on, question came up, well, how long would it take? Approximately a max of about 30 minutes for the typical operatory, assuming that it's sized appropriately. And there you go. And the other part that's really great, because it's continuous, we have patients and staff constantly walking in and out of our operatories. How nice to know that it's a continuous bubble as well.
Yeah.
Again, I thank everybody for their questions. Please feel free to email them to any one of the contacts. And again, Dr. Birx, Dr. Collins, thank you. ActivePure, great stuff. Thank you.
Thank you.
Excellent. Thank you to all three of you for the great information. Like Dr. Cohen said, if anyone has questions that we were unable to answer, please feel free to reach out to any of those email addresses shown on screen. Tonight's webinar was recorded, so we'll get that out to you guys in the next week or so. With that, we are done. So thank you all for attending and hope everyone has a great night.